Well, I very much want to thank the ZERO Prostate Cancer Organization for the opportunity to join you here today. My name is Steve Borgian. I'm the chair of the Department of Urology at the Mayo Clinic in Rochester, and I will be speaking this afternoon about managing prostate cancer recurrence. And when we use the term recurrence here, we're going to be speaking about a PSA level that becomes rising and detectable after initial treatment for a diagnosis of prostate cancer. My financial disclosures are listed here. They're all in the area of bladder cancer, so they are not relevant to the topic I'm going to be speaking about today. I do want to acknowledge that the American Urological Association, together with other societies, have put together recent national guidelines that are now available for salvage therapy in prostate cancer. Salvage therapy, again, is the term used for treatment of patients who experience a recurrence of their disease after initial therapy. And I had the privilege of participating on this guideline panel. This is now available for use. There's really three subjects that I hope to cover here in the next few minutes. The first is, how do we define recurrence? And again, when we talk about the recurrence, we're going to talk about biochemical recurrence, which is known as a PSA level that is detectable and rising after treatment. We'll understand a little bit about the long-term natural history of biochemical recurrence, and then we will cover the two currently utilized treatment options, including radiation therapy. And again, we've called it salvage radiation because it's radiation therapy for a PSA that is rising after surgery. And we'll finish by talking about systemic or medical therapy, again, for biochemical recurrence using the abbreviation BCR. Before we even get to the experience of recurrence, the question is often asked, how should patients be followed after they receive surgery or radiation or definitive therapy for a prostate cancer diagnosis? And again, here, the American Urological Association has provided us with guidelines on how patients should be followed. They tell us specifically that patients should be monitored after therapy with both PSA and symptom assessment. This is a clear acknowledgement of the importance of monitoring the cancer outcomes with a PSA, as well as the potential impact of any prostate cancer therapy on patients' quality of life, including urinary and sexual function, by a symptom assessment. The guidelines also have a statement, as you can see, number 44 here, that it encourage clinicians to offer patients community engagement with professional resources. Again, with the organizations such as ZERO Prostate Cancer, understanding the needs of the patient and the multidisciplinary opportunities for input in follow-up of patients after primary therapy. How often should we be testing a PSA after treatment for prostate cancer? The guidelines offer this sort of rough schedule that can be utilized. What you can see here is that PSA testing decreases in frequency over time as it gets farther out from the time of primary treatment. But again, these are just guidelines to use, and the precise intervals at which PSA may be monitored after surgery or radiation can be based on a patient's age, a patient's medical comorbidities, a patient's disease risk, and importantly, a patient's preferences. So understanding now how our guidelines recommend that we follow patients, the next question is, how do we define recurrence? And specifically, as I mentioned, biochemical recurrence, which means a rising PSA value after therapy. Our guidelines tell us that a biochemical recurrence after surgery or prostatectomy should be defined as a PSA level greater than or equal to 0.2, with a second confirmatory value also greater than or equal to 0.2. So a very important take-home point from my talk here is that no definition and no treatment should be enacted on the basis of a single PSA alone, but our guidelines tell us that true recurrence is defined by a confirmatory value of greater than or equal to 0.2. Now, what do we understand about the natural history of biochemical recurrence? It's been estimated that biochemical recurrence occurs in up to a third of patients following surgery. But what's really important to understand is that the natural history of a detectable PSA after surgery is quite heterogeneous, meaning that PSA elevation nearly always comes before progression to metastatic disease or death from prostate cancer. However, critical to understand is that a rising PSA or a detectable PSA after surgery certainly does not always translate into systemic progression or death from prostate cancer. There are many, many more patients with a detectable PSA after surgery than there are who experience progression to metastatic disease. It's critically important, therefore, to remember the age and the comorbidity status of patients. Patients with prostate cancer are often over the age of 60. They have competing health risks, diabetes, coronary artery disease, and other medical issues. And in fact, there has been one published study that showed that patients with biochemical recurrence after surgery, so a rising PSA after surgery, were as likely to die in the next 15 years from their competing health risks as they were from prostate cancer. Now, it's also important to understand that all patients with the same detectable level of a PSA after surgery are not at the same risk of experiencing subsequent progression of disease. This was a study put together by investigators at the Cleveland Clinic, where they looked at 14 different ways that we could define biochemical recurrence or a detectable PSA after surgery. They generated curves that look like this. But really, the important take-home point from their paper was that the optimal way to define prostate cancer recurrence after surgery depends on the patient's disease risk. So if a patient has high-risk disease, which they assessed as a predicted 5-year progression-free survival less than 50%, the best definition of recurrence was just one PSA greater than or equal to 0.05. On the other hand, for a patient whose disease parameters indicated low-risk disease, their Gleason score, their stage, that definition of recurrence for that patient might be a PSA greater than or equal to 0.4 and rising. So the take-home point is to communicate with your physician about your PSA level after treatment and how that correlates with your disease risk. So there may be a different threshold to define recurrence and, most importantly, to institute treatment depending on a patient's disease risk. Now, is there any way to do what we would call early detection of recurrence after treatment? There are assays, prostate cancer tests known as ultrasensitive PSAs. These are ways of detecting PSA values at extremely low levels, for example, less than 0.1. Our new guidelines tell us that we may use what's known as ultrasensitive PSA assays in patients for whom we would be considering salvage radiation therapy. So a patient has surgery, is found to have particularly high-risk features. Ultrasensitive PSAs, which can detect recurrence at very low levels, may be used. Is there any benefit to ultrasensitive PSA? This was a study done by the group at NYU that found that higher values of ultrasensitive PSA actually correlated with increased risks of what we would call conventional or guideline biochemical recurrence greater than or equal to 0.2. But what's really important is that we understand the limitations of ultrasensitive PSA tests. We don't have prospective tests that have evaluated the ability of ultrasensitive PSAs to guide further therapy. We don't have specific and validated cut points of ultrasensitive PSA values. And as I mentioned, many more patients will have a detectable PSA than will ever go on to develop metastatic disease. And ultrasensitive PSA can detect an indolent recurrence or even reflect the presence of benign prostate tissue residual after surgery. And therefore, the guidelines emphasize quite clearly that we shouldn't act on a single ultrasensitive PSA, but for patients who have a detectable ultrasensitive PSA, we should confirm a rising trend before proceeding with therapy. So again, a very consistent message: don't act on a single PSA, don't act on a single ultrasensitive PSA. It needs to be a discussion with your physician. How about the time course and natural history of biochemical recurrence? I mentioned earlier that the natural history is heterogeneous. It is also quite prolonged. This was a study done by the group at Johns Hopkins that followed 304 patients who had experienced biochemical recurrence after surgery for a mean of just over 5 years. What they found was that approximately 1/3 of patients with biochemical recurrence developed metastatic disease during that time. The median time from biochemical recurrence to the development of metastatic disease was 8 years. The median time from metastatic disease to death from prostate cancer was 5 years, which gives a window of 13 years from the diagnosis of biochemical recurrence to death from prostate cancer. And when we look at the time this was published in 1999, 25 years ago, this predates even the new and much better systemic therapies that we now have for patients with advanced disease. So I show you these data to emphasize that the natural history of prostate cancer recurrence can be quite prolonged. emphasizing the importance of considering a patient's age, their medical status, and their preferences before making treatment decisions. And in fact, when we look at our new AUA guidelines, they tell us that we should use prognostic factors like the PSA kinetics, such as doubling time, the Gleason score, pathologic stage, in order to counsel patients about their risk of clinical progression or metastatic disease when they have a detectable PSA. And the guidelines include this table here, which outlines some of what are considered to be high-risk features. Higher stage, higher Gleason grade group, lymph node positive disease are among these features. What about imaging? Should patients who have their PSA become detectable after surgery get imaging? Now, when we talk about imaging in prostate cancer, there's what's known as conventional imaging, which refers to bone scans and CTs and MRIs, and there's what's increasingly become known as molecular or next generation imaging, which in 2024 really means a PSMA PET scan. What are the data to support PSMA PET scans for detecting recurrent prostate cancer? This was a study of 635 patients who had biochemical recurrence of their PSA after either surgery or radiation. And what they found was that the positive predictive value of getting a PSMA PET scan in these patients was 0.92, which is quite high. They also found, very importantly, that the likelihood of the PSMA PET scan to detect recurrent disease increased with the PSA at the time that the men were getting their scan. So what you can see in this table is the higher the PSA when you get your PSMA PET scan, the more likely it is that the scan will detect recurrent disease. So for patients who have a PSA over 5 after treatment, when they had their PET scan, 97% had a positive scan. But what's interesting to note is that even for patients with a very low recurrent PSA, less than 0.5, nearly 40% had a PSMA PET scan that was positive, suggesting that these scans may be of value even with patients with a low and detectable PSA. This was what's known as the Condor trial. It's a phase 3 multi-center trial, 208 patients with PSA recurrence, again, after either surgery or radiation as their primary prostate cancer treatment. And what they found was that approximately in 85% of cases was there correct localization of disease recurrence with the scan, and 64% of patients had actually a change in how their PSA recurrence was going to be managed directly based on the results of the scan. Very similar to the other study I just showed you, this study also reported that the likelihood of the scan for detecting recurrence directly correlated with the PSA value at the time the scan was obtained. So for patients who had a detectable PSA that was less than 0.5, 36% had a positive scan. For patients who had a detectable PSA greater than 5, 97%, very similar to data to the other study, had a positive PSMA scan. So take-home points here. What do our guidelines tell us about imaging? In patients with biochemical recurrence, we may obtain a PSMA PET scan instead of getting that conventional imaging, or if the conventional imaging is obtained and is negative, because PSMA PET scans can detect disease more sensitively. And for patients that were thinking about using treatment for their PSA recurrence, like salvage radiation, we should get a PSMA PET scan before doing that. Why? Because getting that type of a scan will exclude patients from getting local pelvic therapy if they have disease that is documented as outside the pelvis or metastatic disease. Now, it's also really important to understand the limitations of a PSMA PET scan. What do I mean by this? I mean, if you have had surgery and your PSA becomes detectable and you get a PSMA PET scan and that scan is negative, it's very important, as our guidelines state here, that we don't withhold salvage radiation if that scan is negative. Patients should still receive salvage radiation even if the scan is negative. Why? Because these scans are not sensitive enough at very low levels of PSAs, and that microscopic disease still may be present, which would be effectively treated with radiation. So when we have a PSA recurrence, we're getting that PSMA PET scan to exclude the presence of disease outside the pelvis, not to decide whether we're going to do radiation or not. A very important question when we think about using radiation therapy for a PSA recurrence is whether or not it can impact the natural history of biochemical recurrence. That same group at Johns Hopkins did this study, 635 men with biochemical recurrence after surgery. Of these patients, 238 got salvage radiation. And what they found was that among men with biochemical recurrence, those who received salvage radiation had significantly better cancer-specific survival and significantly better overall survival, suggesting a potential benefit of using salvage radiation therapy for biochemical recurrence. Now, when we talk about salvage radiation, we use the term early salvage radiation because what we have shown and what we need to be counseling our patients is that if we're going to give radiation for a PSA recurrence, it is most effective when delivered at lower levels of PSA. And that's the term early salvage radiation. This, in fact, is a study from our Mayo Clinic radiation oncology group, a little over 1,100 men who got salvage radiation for a PSA recurrence after surgery. They were followed for nearly 9 years. And what they showed was a key prognostic factor was the pre-salvage radiation therapy PSA, such that what you can see from these curves are for patients who got salvage radiation with a PSA less than 0.5, blue lines here, those patients had significantly lower risks of developing a second PSA recurrence, of developing metastatic disease, and of death from prostate cancer, suggesting again that early salvage radiation therapy is of benefit. And in fact, when you look at our new guidelines, they tell us that we should be providing salvage radiation when the PSA is less than 0.5. And for patients who are at high risk, again, think about your Gleason grade, think about your tumor stage, lymph nodes, we may even offer the salvage radiation with a PSA less than 0.2. A common question that comes up is whether we should add androgen deprivation therapy or hormones together with salvage radiation therapy. There are several prospective clinical trials that have actually investigated this question. This is a French study that randomized men who were getting salvage radiation to 6 months of androgen deprivation therapy or no. They enrolled over 700 patients, and with a follow-up of just over 5 years, they showed that adding 6 months of androgen deprivation therapy to salvage radiation significantly improved patients' progression-free survival. They then followed these patients long-term and confirmed the results of the primary analysis, emphasizing the added benefit of androgen deprivation therapy with salvage radiation. This is a second trial that investigated the same question, adding androgen deprivation therapy. Here it was used oral high-dose bicalutamide together with salvage radiation, again over 700 patients. The follow-up in this study was 13 years, and with that long-term follow-up, they showed that adding bicalutamide to salvage radiation significantly improved overall survival and significantly decreased the risk of death from prostate cancer. So when you look at our new AUA guidelines, they tell us that for patients getting salvage radiation, we should offer androgen deprivation therapy for patients with any high-risk features. For patients with lymph node positive disease who are getting radiation, we should add androgen deprivation therapy. Very importantly, as we know, androgen deprivation therapy does have side effects, and we should counsel patients regarding the potential adverse events, particularly in light of potentially their coexisting medical comorbidities. For patients with no high-risk features who are getting radiation, they may not need androgen deprivation therapy and may be treated with radiation alone. I'll finish with just a few words about the role of systemic therapy or medical treatment for patients with a rising PSA. This has been something that's been studied with traditional androgen deprivation therapy. This was a study of a little over 1,300 patients who had a rising PSA after surgery. As you can see, approximately 1/4 of those got androgen deprivation therapy. And what they found is that in the whole cohort of patients with biochemical recurrence, using androgen deprivation therapy did not delay the development of bone metastatic disease. However, in specific high-risk cohorts of patients, here, high Gleason scores, rapid PSA doubling time or rapidly rising PSA, using early androgen deprivation therapy did delay the development of metastatic and specifically bone metastatic disease, emphasizing the importance of risk assessment. Our AUA guidelines tell us that for patients who've had local therapy and have a rising PSA, we shouldn't routinely put those patients on androgen deprivation, acknowledging the adverse health consequences. But if we do use androgen deprivation therapy, we should consider an intermittent androgen deprivation therapy schedule. And finally, what do we have new and upcoming in this area? This was a study published in the New England Journal of Medicine at the very end of last year, known as the EMBARK trial. It took patients who had biochemical recurrence of their PSA after either surgery, radiation, or both surgery and radiation, and had a rapidly rising PSA. and it randomized them 1:1:1, 3 arms, enzalutamide plus Lupron, Lupron alone, or enzalutamide alone. The primary endpoint in this study was metastasis-free survival, and the follow-up was just over 5 years. What the study showed was that enzalutamide plus Lupron or enzalutamide alone significantly improved patients' metastasis-free survival compared to Lupron alone. They looked at a variety of different secondary endpoints, PSA progression, overall survival, distant metastatic disease, first use of next anti-neoplastic therapy, and very consistently adding enzalutamide as systemic therapy improved each of the outcome measures here. They also looked at quality of life, and they found that the addition of enzalutamide did not have a substantial impact on quality of life deterioration. And in fact, in November of 2023, the FDA approved enzalutamide alone or with androgen deprivation therapy for patients with PSA recurrence after prostate cancer therapy. I think it's important that we also understand the potential questions that remain about enzalutamide. When should we initiate treatment? Do all patients with biochemical recurrence need medical systemic therapy? How would this impact the ability to receive subsequent therapies? And of course, the cost. And I would encourage patients to have these open discussions with these questions with their treating physician when they experience PSA recurrence. So what do I want to leave you with in conclusion about managing a PSA recurrence after prostate cancer treatment? PSA surveillance is the recommended management for patients who've had definitive therapy. The option exists to use salvage radiation if patients experience biochemical recurrence, and that's an approach favored over using adjuvant radiation. I think we should know how our national organization, the American Urological Association, or AUA, defines biochemical recurrence. That's a PSA greater than or equal to 0.2 with a confirmatory value. But I think it's also important that we know that the natural history of a PSA recurrence can be heterogeneous and can be quite prolonged. So consider the patient's risk factors and consider the medical risk factors such as age and comorbidity status. How do we evaluate biochemical recurrence? Use a PSMA PET, but remember its limitations. And if that scan is negative, don't deny a patient from getting salvage prostate radiotherapy. If we're going to do salvage radiation, earlier is better, less than 0.5 for sure, maybe even less than 0.2. The pelvic lymph nodes may also be radiated at that time, and we should be offering concurrent androgen deprivation therapy for patients with high-risk features. When we think about systemic therapy or medical therapy for a rising PSA, we shouldn't utilize androgen deprivation alone routinely. If we do it, it should be intermittent. We do now have enzalutamide FDA approved with or without concurrent androgen deprivation therapy, but it's critical that we consider its toxicity, cost, and what we understand to be the frequent long-term natural history of biochemical recurrence. So with that, I'm going to stop. I'm going to thank you again for this opportunity to provide this lecture and participate here today.